What led to the Primary Care Development Agency set up in 1992 was a combination of evidence generated from a model that WHO exploited in 8 local governments using what we call institutional management support and providing technical oversight over a period of time to local governments. That worked, and by 1991, when the high-level team reviewed it, it came to a conclusion that, listen, this is what is appropriate for a Nigerian context and should be rolled out.
The agency has actually come a long way. Look at all the efforts that started even before we joined the agency, the MPI, the effort at revitalizing immunization to actually ensure that we stop the transmission of vaccine-preventable diseases through the most cost-effective tool, and that's vaccination. So when the 2 agencies merged, the effort actually continued to ensure that that immunization agenda is carried through and through. And of course, the primary healthcare services to actually prevent infant and maternal death through other interventions also continued.
By 2016, the agency had made substantial success, but it was in dire straits. It was bedeviled by a number of serious challenges. In terms of governance, there was poor accountability, weak financial management process, and poor alignment with donors and partners as they made plans without consideration for national priority. The wild polio virus has relapsed towards wiping out the gains achieved over the years, and routine immunization coverage was at its lowest at 33%. Primary health care centers across the country were in shambles, devoid of the necessary manpower, equipment, drugs, and essential commodities. There were widespread concerns on the ability of the agency to effectively and efficiently manage donor resources. This led to the suspension of the country from accessing donor funds.
In most places, the primary healthcare system actually is responsible for providing health service delivery for a greater percentage of people. In Nigeria, it's not really like that because the facilities are really not there, the human resources are hardly there, and even the ones there are, in quotes, they are living. So you find people going to secondary facilities, I mean general hospitals, for malaria, for diarrhea, for basic things. The result is that the secondary facilities are overburdened. They don't have time to do what they actually should do, which is the more complicated cases. You go to teaching hospital, you see people coming for diarrhea. You see people coming for outrageously basic things. So they are distracted from research, they are distracted from everything that they ought to do, and they're treating basic things.
It was against this backdrop that Dr. Faisal Shwaib was appointed to the position of the Executive Director of the agency in 2017.
We had to hit the ground running, so there was no honeymoon period to address this issue in a leisurely manner, because we were facing an outbreak of white polio viruses, low routine immunization, low donor confidence in what we were doing, weak financial management systems. There were also issues around staff morale.
Upon resumption, Dr. Faisal set out 4 main goals for himself, the management of the agency and its partners. The 4 cardinal points were: 1. Close out on polio. 2. Strengthen immunization and improve coverage by 80% by 2028, while strengthening the supply chain system. 3. Revitalize primary health care in Nigeria. 4. Improve NPHCDA's governance, financial management processes, and accountability.
Polio would have been declared eradicated in 2016. Unfortunately, a case emerged, and that case was not surprising because all along the surveillance was not strong enough to detect cases, especially in security compromised areas. So all along we were only considering those areas that we could reach. But when the surveillance became strong enough, with the introduction of so many innovations, so a case was detected and then it was all over again.
In the end, 4 cases of the wild polio virus were discovered in the war-torn state. All of the victims were children who had been staying with their families in crowded refugee camps, part of over 1 million refugees scattered across the country as a result of the horrific activities of Boko Haram. This time, the problem was even bigger and its challenges humongous. To get around this problem, the ED and CEO leveraged his extensive knowledge and experience as the former Chief Operations Officer and Deputy Incident Manager of the National Polio Emergency Operations Center. He got the NPHCDA and its partners to throw everything they had at polio. The objective was twofold: to maintain the status in states that are already polio-free, and to kick it out of Borno and hopefully Nigeria for good. To this end, the polio endgame was launched. As a result, many innovative initiatives now being used in other parts of the world were introduced to deal with this very unique challenge of interrupting the spread of a virus in what was effectively a war zone. Some of these initiatives included: 1. The Buratai Initiative. 2. Reaching Every Settlement, RES. 3. Reaching Inaccessible Children, RIC. 4. Deployment of Community Informants. 5. Tracking Mobile Population. 6. Covert operations to take vaccines into Boko Haram-controlled areas. 7. Refugee Camp Initiatives. 8. Monitoring and surveillance. 9. Deployment of technologies like Avadar, amongst others. All these initiatives led to the interruption of the spread of the wild polio virus.
Nigeria was declared WPV-free in August of 2020. That would have taken place in 2019, right? But for reasons of Nigeria being a very vast country, the documentation validation by the Africa Regional Commission of the Eradication of Poliomyelitis Eradication and Certification, that's ARCC, had to divide the country into 2 bits, right, north and south, so that the claim we've submitted to them as independent body of experts that in charge of ensuring that the African region is wild poliovirus free, had to visit the southern part of the country to validate the documentation that we've submitted in terms of routine immunization, in terms of the quality of our supplemental immunization activities, in terms of surveillance, which is a key component of polio eradication, in terms of routine immunization, which is also another fundamental pillar of polio eradication, to validate the data that we submitted.
I was in Delta and in Edu and did a 2-week verification visit where we interviewed and looked at documentation at all levels of the health system within Nigeria. So national level, the state level, the local government area, and most importantly, what is happening actually in the community as well. And then we visited the 3 zones in the north. And I was in Bauchi and in Borno, and my colleagues were in other states as well, in the north central zone and in the northwest zone. So we really get a snapshot of what is happening in the country related to polio eradication, right from the national level, right through to the community level.
And that led to the African Regional Certification Commission certifying Nigeria as wild polio virus free in 2020. So we did not look back. We stood, on the shoulders of giants. We recognized the incredible work that the people that came before us have done, but we also tried to understand what the challenges were, what the gaps were from the past. So we pull together our donors, our partners, engaged even much more deeply with the traditional and our religious leaders to make sure that we eradicated the wild polio viruses.
This was followed by an official certification ceremony on the 25th of August, 2020.
Before 2017, in immunization, we were dealing more with administrative coverage. From the admin platform, at the end of the year, you see 100% coverage, 105% coverage, 110% coverage nationally. Meanwhile, when we come to survey, in surveys, 2016-2017 survey mixed NICs scored 37. In the past, before then, we would have ignored the mixed NICs. We'll feel good, you know, like people want to crack jokes. Like, I feel good, they want to say, admin coverage was 104%. That same year, admin coverage was 104%. But mixed NICs gave us 33%. What was different is the fact that the current leadership, Dr. Faisal, took a decision. What we are looking at is this 33%. We are not going to consider 104%. Why are we 33%? What should we do? So he called together all the partners working with the government for over a period of 3 months. We sat together to analyze, to look at what the issues were that was responsible for that poor coverage. And why was there a wide gap between the admin and survey so that we can bridge the gap.
In collaboration with stakeholders, the NPHCDA declared a state of public health concern on routine immunization on June 17, 2017. This led to the establishment of the National Emergency Routine Immunization Coordination Center, NERIC.
I can assure you that center meets every day since 4th of July 2017 to review what is happening in routine immunization. It's not only having government, it has partners making up membership.
To ensure this is properly entrenched, NPHCDA supported the establishment of a similar structure named CERIC in all 36 states, plus the FCT, and LERIC in the 774 local government areas in Nigeria. The objective being to coordinate efforts at revamping routine immunization coverage across the country. This was closely followed with the development of a 10-year strategic plan, NSI-PPS, which laid out an investment case for immunization and PHC system strengthening in the country. To date, in addition to vaccines already being offered, Rota, IPV2, and MCV2 vaccines have been successfully introduced into the Nigerian immunization schedule, and plans are at an advanced stage to introduce all essential HPV vaccines to assist in the fight against cancer.
HPV, or human papillomavirus, is a virus that we know can cause warts, but also can cause cervical cancer. Within the last decade, a vaccine has been licensed and WHO pre-qualified for use and has been demonstrated to be safe and effective in not only preventing the different types of HPV that cause warts, but also in preventing cervical cancer. We work with NPHCDA to introduce that in a way that they will be received and accepted by communities. We recently worked with them to introduce rotavirus. So diarrheal illness is one of the biggest killers in Africa. And rotavirus vaccine, which has been used in the developed world for years, has now been introduced in Nigeria, which is an important game changer.
Towards stimulating demand and generation of service in the communities, the agency introduced the Community Health Influencers Promoters Program, CHIPS. The CHIPS program is designed to strengthen the community component of PHC and harmonize all activities at community level, and as well bring healthcare services closer to households, especially in rural and underserved communities.
CHIPS doesn't do a lot of things. We suffered our environments. We went to house by house, counsel them wash, to how to protect them from malaria. We counsel them HIV, how to prevent ourselves from HIV. We check on pregnant women, tell them about how important of antenatal is. We refer them to antenatal, but let them know that antenatal is very good to them.
Primary health care has two components. There's the health facility component and the community component. Before now, the community component of primary health care has been a really neglected aspect. And all the services, whether it's health promotion, health prevention, and basic services that's approved within the policy is being provided by the CHIPS program. Now, before the CHIPS program, as I said, we had the VCMs playing that role for polio. So now that role has been integrated into the CHIPS program, and we have the CHIPS agents that go house to house. They identify the caregivers, identify the children under 5, look at their immunization status, and refer them to the health facilities.
The agency is also supporting the states to improve demand generation through the CHIPS program.
The entire concept of the CHIPS program came through the NPHCDA, and till date they still provide a lot of technical support, and where necessary they provide also financial and material support in terms of the data generating tools. They've also been instrumental in the training of our staff or agents across the communities. It has enabled us to reach more households, especially in hard-to-reach areas where normally it is very difficult to take routine services. So that has covered some gaps, and it has strengthened the way we partner and enhance community ownership of this program.
Since its launch, the first year we piloted the program in 1 state. Then the second year we're in 5 states. Presently, we're in 34 states of the Federation. They've started implementation, and we have over 21,000 CHIPS personnel providing services across wards in their communities.
Still on ensuring demand generation and uptake of PHC services, the agency has continued the excellent collaboration with strategic institutions. It has not only succeeded in strengthening the Northern Traditional and Religious Leaders Council, but also in replicating the same collaboration in the southern part of the country to increase the uptake of PHC and immunization services at the lower levels.
The Southwest Traditional Leaders Committee on Primary Care Delivery was inaugurated on the 2nd of September 2021 by the Honorable Minister of Health in the Palace of the Oni of Ife. That was a major breakthrough in the South. And a year after, that is on the 16th of September 2022, the Southeast Traditional Leaders Committee on PHC was inaugurated in Enugu. So the South, we had to go zonally. Lessons we have learned from the North, that's the NTLC, for over a decade, has helped us to fine-tune the processes and even the operational guideline for the southern states that are coming on board.
We have our stakeholders that cut across the development partners. We equally have our own other stakeholders, religious leaders, community leaders, gatekeepers within our communities were expected to advocate for support to secure the buy-in of these numerous stakeholders in order to collaborate with us, in order to ensure that we project the programs. So for us to be able to do that, we need to ensure that each and every stakeholder is brought on board. We secure his buy-in, and for what reason? For us to be able to collaborate. We know government cannot do it alone. So we need each and every stakeholder to be brought on board to ensure that we are all in alignment with the mandate of the National Primary Healthcare Development Agency, and which is what? Ensuring that we bring health closer to communities for us to be able to achieve what you call universal health coverage.
Closely linked to the success of increasing the rate of immunization is the issuance of an effective vaccines supply chain, and as at 2017, this needed serious attention.
The 2014 EVMA, the assessment clearly stated that we had storage capacity gaps in the country. And then the 2017 too also highlighted it.
We had a situation where when vaccines come, we hardly had where to keep them. We had to move vaccines from one place to the other. You find out that even at the LGA levels, they did not have storage capacity. They didn't have any refrigerator for storing vaccines. So they had to keep the vaccines, some of them at the LGA, some they had to store in other health facilities. The whole idea for storage of vaccines is for you to be able to keep at least 2 quarters supply at the national and be able to have a quarter supply at the zonal level and be able to have other supplies too at the LGA, and the health facilities too should be able to keep vaccines. So the consequence meant that we had to have so many shipments. We have up to 200 and more shipments in a year.
Towards improving vaccine supply, distribution and storage, the agency procured and deployed cold chain equipment to all the political wards in the country.
Now, at the lower level, at the state, we've increased the number of walk-in cold rooms, which are used for storage of vaccines. And for the lower levels, we have moved from 39.5% ward having cold chain equipment to 94% of the wards now having solar direct drives.
As with all its operations, the agency has also deployed technology to ensure up-to-the-minute information on stock levels and performance across the vaccine storage and distribution chain. This it does through the Electronic Logistics Management Information System, LMIS.
It's a software. It's a tool that manages the data for vaccines and devices. You enter all the data you have, it does your distribution, you do your issuance, your receipt on that particular tool. So, and what it's web-based, that means at the national level, I'm able to see the transactions that happen at other level of the supply chain.
To further ensure last-mile monitoring of the availability and vaccines stock levels at the lower level, the agency has redesigned its vaccine storage architecture with the creation of 3 vaccine hubs to effectively manage the vaccine supply chain across the country.
The 3 hubs is a progressive acknowledgement and forward thinking, because you know that you will need vaccines with increasing populations. We have a birth cohort of about 7 million Nigerians that are born every year. You do know that if you need to make available vaccines for these individuals, you will have to increase the storage space for them. This is why we collaborated with our partners and came up with the ideas around building state-of-the-art hubs in Abuja, in Lagos, and Kano to be able to accommodate all of the logistics requirements for vaccines and other commodities.
At the end of the day, we are going to have 3 mega hubs. We are going to have 3 different entry points to 3 international airports. Instead of the pressure to be on the Abuja hub, we are going to have other entry points.
Construction work on the vaccine hubs has commenced, and they are expected to come on stream by 2025. On the vaccine storage and management side of things, a lot has been achieved.
Every ward in this country, now at least one facility in every ward in this country has a functional cold chain equipment. That means we have taken the vaccines nearer to the people. So in the past, the healthcare worker would always complain that they are using their out-of-pocket expenses to go and collect vaccines from the LGU cold store. But now that is ruled out. So these are the facilities that we call the Apex facilities. So any facility that doesn't have a cold chain equipment now is going to be a cascade facility, and they are now closer to where they are going to collect the vaccines. So with that, we've been able to address the issue of coverage. The coverage has increased, and we've also been able to address the issue of equity for immunization coverage in the country.
When it comes to routine immunization, despite the interruption caused by the COVID-19 pandemic, routine immunization coverage has increased from 33% to 57% based on the 2021 Mix-NICS survey. This globally unprecedented jump in RI coverage in such a short period is a clear testimony that all the strategies deployed by the agency are working.
This is something that we've not seen for maybe 20, 30 years, a consistent progress in routine immunization coverage. What we've seen in the past has been an undulating kind of situation. Some improvement, a dip, some improvement, a dip until in 2016, 2017, when the Mix-NICS survey made it very clear that Nigeria was not doing well.
By 2020, the agency was well on its way to achieving most of its set goals when the whole world was disrupted by the COVID-19 pandemic. As with the rest of the world, this led to a halt on most activities, and surviving the pandemic took center stage. The prediction for the impact of COVID-19 in Nigeria was bleak. The body count was expected to be massive. But thanks to visionary and pragmatic leadership, the story Nigeria has to tell is one of success.
NPHCDA, I think, took leadership from the beginning, at the onset. When we had the first few COVID cases, NPHCDA recognized that at the end of the day, this is going to be a primary health care emergency. The ED pulled partners now to say, oh, look, if we get a vaccine, or if a vaccine is finally developed for COVID, NPHCDA will have a lot of responsibility. So rather than wait until that happens, let's begin to build systems that we can use for COVID vaccination, being that it is an adult vaccination one, so it's different from what they are used to. They're used to childhood vaccine, right? So brought in all the partnership, and then we started the planning process.
We're able to train over 240,000 primary healthcare workers across the country, apart from the staff of NPHCDA, but all across the states. This is one of the reasons why we did not experience widespread community transmission of COVID-19, because the health workers were trained, they knew how to use their personal protective equipment, they knew how to identify the high-risk symptoms of people with COVID-19. We're able to ensure that these health workers were also well-trained to deliver COVID-19 vaccinations.
When it came down to an innovative idea that could sort of push or harness everyone's energies towards boosting the uptake of the vaccine, you could see NPHCDA leadership engaging very, very actively, both with the international partners and with Nigerian leaders. Like they got movie stars, they got the governors forum, they got religious leaders, influencers, and tapped into that way of messaging Because there was a lot of hesitancy, if you remember.
The country faced a huge challenge, that it was that very little vaccines of COVID-19 were administered. At the time, less than 15 million doses of vaccines were administered. What we're doing with NPHCDA and partners over the next few months was to change that picture completely. In some months, we were able to vaccinate more than 9 million people in one single month.
For the agency, data and its use in decision-making would be a key element in the success of the fight against COVID. To this end, the agency developed and deployed the Electronic Management of Immunization Data, EMID, which provides a harmonized system for reporting programmatic and logistic data to inform decision-making, which has improved accountability in data reporting. This turned out to be a major game changer.
It looked very difficult at the beginning. Nobody thought, if you are in Nigeria, you know how it was from the beginning. Nobody thought we could have reached 5 million persons. But the truth is, with the leadership we've had, heavily supported by our partners and donors, as at today, we have reached out to about 79,236,402 persons with the first dose, which is about 68.4% of the target. Now, when we look at those that have been fully vaccinated, of these 79 million, about 67,428,602 have been fully vaccinated, and about 11.5 million have received their booster. When you look at the total number of doses, about 113.2 million doses have been administered either as first or second or booster. Imagine 113 million doses administered in Nigeria alone.
This did not go unnoticed, as the WHO commended the country on the unusual resilience and adjudged the country's COVID-19 response as one of the best in the world.
We have almost 30,000 PHC facilities existing, but the problem is that the infrastructure in those facilities are not what they should be.
Facilities were mostly non-existent. Health workers were not living in them. They were not offering services adequately. Some of the visits I conducted in the evening hours, I didn't see anybody. Most of the gates were locked. And I made sure I told virtually or most of the states in my zone. I have 5 states, and I made sure I did spot checks to see how these primary health facilities were being used. I was looking out to see if people were on admission. Most of them, I didn't see any. People were just coming and they were quickly going out. And even for the few that were rendering service, I asked questions and I could see that they were not necessarily the right combination of officers you would expect to have in a primary health care centers. Most of them didn't have accommodation for the nurses, for the midwives. Most of them didn't have light, and they were not able to offer service for even greater times of the greater part of the day, including the night.
The building is not big enough, and the things have been weighing out. You can see our door. There are some things, and even the equipment. Most of them, I brought them myself from my house. And this lab, we don't have good lab here. If we have good lab, we will not be referring people outside. So we do refer them outside before they will come back with the result. And if we have more than 1 or 2 patients, there's nowhere to admit them. We have to refer them back.
But most of the challenges we are having here is inadequate staff. We don't have much hands and this place is a little bit busy. We need nurse, midwives, shoes. We need shoes. We need health management information officer, at least one person. Then we also need a medical personnel, a doctor.
Actually, almost all the office we are using, everything is broken. There's nothing good inside the office because the materials we have is not enough for us. When we go to the laboratory, there's nothing there to write home about it. No instrument for the tests. There's nothing at all. Like materials for the test, we don't have it. And then when we go to drugstore, actually, because there is no enough money to buy drugs, the drug is not enough. There are so many things we need that we need to take care of patients. If they comes, they will not get it here.
Right. So this is why when we came on board, we made it very clear what the standards were, and we are working towards that standard. We identified that we needed one functional primary healthcare center per political ward, and we worked towards that to make sure that we had the full complement of health workers, in the primary healthcare center, the right infrastructure, making sure that this level 2 primary healthcare center was well fenced, has the quarters for the health workers, has water, solar powered, electricity, the right drugs, and then the commodities, making sure all of that are in sync in one location. That is really what we call a functionality of a primary healthcare system.
This is part of the reasoning that led to the establishment of the Basic Healthcare Fund in 2000.
So the Basic Healthcare Provision Fund is actually a catalytic funding for primary healthcare in Nigeria. And this is one of the most recent and comprehensive commitments that the federal government of Nigeria has shown to improving primary healthcare in Nigeria. And it is enshrined in the National Health Act, in Section 11 of that Act, that the federal government of Nigeria will commit not less than 1% of the considered federal revenue of the federal government and pull that into the Basic Care Provision Fund. So the idea of the fund really was to try to address some of the fundamental challenges that plague primary health care, which has been the result of various surveys over time. And the issues have remained fairly constant because the interventions have never been holistic to just take care of all the problems in one bucket, as opposed to parts implementation, particularly around renovations. So together, this fund tries to address some of the fundamental things that have been challenging primary health care.
But before now, this was being massively abused.
We made it abundantly clear that this is a quantum of resources that should not be spent in Abuja. That is why once that money is set aside from the Consolidated Revenue Fund, 50% of it goes to the NHIA pathway, that is the National Health Insurance Authority pathway. 45% passes through the National Primary Healthcare Development Agency gateway. What it means is that the resources are passing as a gateway. We don't have the authority to utilize them here. The money goes directly to the state, and from the state directly to the health centers, so that these resources are not available for people to line their pockets with. This was a deliberate attempt so that we move away from the days when money is released and then people sit in Abuja and divide it up themselves.
To ensure its proper utilization, the agency encouraged the creation of state healthcare development agencies, so funding can be sent directly to them. Today, through the NPHCDA gateway of the Basic Healthcare Provision Fund, a total of 7,535 facilities are being provided with resources to procure essential drugs, vaccines, consumables, and maintenance of facilities, equipment, and transportation across the 36 states plus the FCT in each of the political wards of the 774 local government areas in the country, including the deployment of midwives, and Community Health Influencer Program chips personnel and service to scale up PHC service among the citizens nationwide.
I think the Basic Care Provision Fund has really impacted on Nigeria and the lives of Nigerians on several levels. The first is in the institutional arrangements. So now, because of the coming up of the Basic Care Provision Funds, we have all states in Nigeria now have functional primary healthcare development boards, which was not the case. In anticipation of the fund, they started coming on board, but with the fund coming on, they all became functional, quickly got their laws in order so that they can function effectively. And even on the insurance part, the fund has been a big catalyst to creating the necessary institutional structures at the state level to really promote and develop primary healthcare. The second thing it has done is that it has also stimulated a bit of widespread investment in primary healthcare, particularly at state level, because to access the fund, they were supposed to do some minimum facelift of their facilities and make efforts to get more health workers into the system to be eligible to get to at least get into the fund.
Another area of major concern to the present management at inception was that of maternal and child mortality.
We have the National Demographic Health Survey that is conducted every 5 years in Nigeria. The last one was conducted in 2018 and the result came out around April 2019. And with the result, it showed that Nigeria was making very little progress in reducing maternal and child mortality. So it was a cause, for concern because the rate at which we were going will not be able to significantly help to reduce this preventable deaths in the country. So a declaration of state of public health concern was made by our executive director about the same time that the results was released. That was in April. And it was a pledge for us to do things differently, to pay more attention to strategies and interventions that would lead to rapid and sustainable reductions in maternal and child mortalities. So with that declaration, NPHCDA was established. And we started work, in NPHCDA. We developed high-impact interventions that would help to address, the causes of these mortalities.
To ensure domestication of the fight at the state level, the agency also encouraged the establishment of state versions of the center, called SEMCHIC.
We're here as a team at the national level, but we know that that is not where the real action takes place. The real action is down there at the community level. So the interventions we designed, we're supporting the states and the local governments to implement these interventions. So as we are here day to day looking at the numbers, seeing what we can do to bring these numbers down, the states are also doing this. And at the same time, we also have the LEMCHICs, which are set up at the local government, closest to communities, who also, they're also a replica of the SEMCHIC and the NPHCDA. And what they do is also trying to see that the women and the children are taken to the facility and they get the right care.
I was so happy when NPHCDA came on board because at least they have opened our eyes, they have trained us in scorecard, we've trained our SEMCHIC members, even our LEMCHIC members, our M&E, so they were able to track those activities and to see that today there is an improvement. So at least today I can confidently beat my chest and said, yes, coming of NPHCDA has really improved our indicators.